Hello everyone, myself Dr. Gaurav Behra, Assistant Professor in Department of Cardiology in UNMICRC Institute of Cardiology. I'll be discussing about evaluating pulmonary arterial hypertension. So the pulmonary arterial hypertension is defined as mean PA pressure of more than 20 mm of mercury at rest as assessed by right heart catheterization. This is gold standard definition. The earlier the mean PA pressure was 25, but when the 6th World Symposium on Pulmonary Hypertension, the guidelines has changed and the numeric has come to 20. And in 2024, the 7th Symposium also concluded the same, that mean PA pressure of 20 as a cutoff to level at pulmonary arterial hypertension. So the two reasons why the cutoff has changed from 25 to 20. There's a large study in UK that showed that most of the people have mean PA pressure at rest 14, which lies between 14. So this is the first reason. And second being, the patient who has of mean PA pressure of 21 to 24, they have high risk of developing overt PH and poorer outcomes. It has been seen by comparing the two groups, those having heart and lung disease and without and heart and lung disease with 21 and 24 millimeter of mercury pressure. So these are the two reasons why the mean PA pressure have been changed from 25 to 20. Now coming to the classification of pH, it is mainly divided into the pre-capillary and the post-capillary. So we can see in this picture that the pre-capillary, the capillary being defined on the basis of the capillary network of the lungs. So the pre-capillary pulmonary hypertension mainly includes the etiology that lies in the pulmonary artery. You can see in the picture. You can see in the picture that pre-capillary, the PA, the capillary that connected to the PA, you can see the dark gray color, and in post-capillary means capillary, beyond the capillaries towards the heart. So the first being pre-capillary, where you can see the mean PA pressure more than 20. You can see in every pre-capillary, isolated post-capillary, and combined pre and post-capillary. The main difference lies in the PAWP, the wedge pressure. The pre-capillary means there is less wedge pressure, means the pathology is in pulmonary artery. So you can see in post-capillary PAWP is more than 15, and in combined you can see the PAWP is 15 as well as PVR is more than 2, means the pathology lies in the PVR. So the PVR mainly indicates the resistance of pulmonary vasculature. We'll be discussing what is that, and the important concept is exercise pH. Like in a patient who have pulmonary hypertension on exercise, so this can be assessed by cardiopulmonary exercise test, that is CPET, where you can see the mean PAP by cardiac output slope. If that is more than 3 mm of mercury per liter per minute, then that is exercise pH. So this is coming to be a new concept, so already discussed. Now this is a picture where you can see the pH in congenital heart disease. We can generalize this as just a pictorial representation. The group 1, the Eisenmenger syndrome, the pH with the congenital heart disease with left to right side, pH with small defect, and the pH with congenital heart disease, corrected congenital heart disease. Now group 2, basically the group 2, it says left heart disease, pulmonary vein stenosis, valve disease, and left heart obstructive diseases. So you can see that there is a group 4 where is a pulmonary arterial obstruction. We can see congenital pulmonary arterial stenosis. What when adult we say the patient CTEPH or chronic thromboembolic pulmonary hypertension. Whereas group 5 that has unclear multifactorial mechanisms. So mainly this chart in congenital heart disease, and in generalized we say the definition has several limitations. Likewise, it does not address the infant if it is less than 3 months old. It fails to account for the impact of PA pressure as on the RV. What the RV is happening with the PA pressure. The third being, it doesn't reflect whether the high PA pressure is due to abnormal pulmonary vasculature bed or due to the blood flow or due to the pulmonary venous pressure. So any patient who has more than 20, you can say it's a PH. But the patient, the level of obstruction, the level of the cause, you cannot identify. So these are the some definition. This is the limitation of this definition. And it fails to account for the PA hypertensive vascular disease. Even the patient who's having PA pressure less than 20, they can have hypertensive vascular disease. So two important terms, the transpulmonary gradient, it is the difference between the mean PA pressure. So the difference between the PA and the LA. So LA, that's the left heart, and the PA. So the transpulmonary, this signifies the gradient between the PA and the LA, the mean LA pressure, and the PVR. So PVR is the measurement of resistance. So the most important side where the resistance has been measured is the capillaries. So PVR is the measurement of resistance in the pulmonary circulation, mainly the capillaries. So when elevated PVR means there is a reduced cross-sectional area. So PVR is TPG by the QP. QP is the pulmonary blood flow. So when you suspect a patient having PH, the things you should look for, the history, what are the symptoms the patient is having, the clinical signs, and what the functional classification of the patient. So after assessing the symptoms, like a patient of PH mainly have symptoms like the patient have decreased functional capacity. So after suspecting the patient, you will go for the investigation like ECG, echo, X-ray, or the pulmonary function test. So if you find no evidence of PH, then there is a less likely the patient is having PH, because you will definitely get a sign of out of this investigation examination that patient has PH. Like you got a cause for PH like this, then you go for heart disease, either it could be a lung disease. So you have to level a patient of PH, you can do cardiac catheterization with vasoreactivity testing. The vasoreactivity testing is an thing that we'll discuss later on. So you can differentiate by the catheterization that patient is having heart disease or the lung disease. So this is the chart you will look for in a patient who's having pulmonary arterial hypertension. So evaluation means the presentation of pulmonary hypertension varies considerably based on following things. Like first with the age of presentation. Like if a patient comes with as an infancy, the different cause at the different age group, like if a patient infant, neonates, and like say a toddler, a patient adolescents, and old age group. Like if a patient, it's a female comes to you of the age group of 15 to 30 or 20s and 30s, you will feel the patient may have idiopathic pulmonary arterial hypertension, or the second patient may have PH due to a congenital heart disease. Usually a VSD or a PDA will present like this. The second being absence of any medical conditions, like a patient is having COPD or any old lung disease or any pulmonary obstructive disease, you will think that patient may have PH related to lung. Third, the severity of the PH. Like if a patient is in mild pulmonary arterial hypertension, you may have very little symptoms. Like, but a patient is having severe PH, they will have different kind of symptoms. And the third and the fourth, the RV function, how the RV is functioning. Like the PH is so severe that now it has caused the RV to fail. Now you will have the symptoms of RV dysfunction. So these are the certain parameters that you will look if in a patient of PH. So signs like dyspnea on exertion, fatigue, syncope, failure to thrive, cough, chest pain, hepatic congestion, pain, anorexia. So these congestive symptoms usually when RV fails you will feel. The chest pain is due to decreased supply, cough, the failure to thrive. This is the feature, failure to thrive. Like if a mother says that child is not gaining weight, so you can think of that patient is having PH or due to any congenital heart disease. So these are some soft symptoms you will notice. And signs, peripheral edema, parasternal heave due to increased PA pressures, and the single and loud second hand sound, mainly the pulmonary component without respiratory variation. Like in a normal patient which has split of second heart sound is very important. When a patient is having severe PH, you will have a single or loud second heart sound. There will be no respiratory variation or very narrow respiratory variation. And the constant ejection click and the presence of PR or TR murmur that will add to the diagnosis of PH. So this is a diagram earlier on the basis of P2. The P2 is normally audible at that particular pulmonary area, but as you move downwards, or the inching method you can use, by going downward. If you can feel the P2 at the apical area, you can appreciate the P2 at apical area, then it is conditioned that patient must be having severe PH. So this is an important finding when you don't have any investigation, when you're auscultating a patient, you're getting P2 in apical area, well, definitely there is patient having severe PH. Now, this is a very important chart where you can see the hyperkinetic and obstructive flow. Like if a patient is having PH due to hyperkinetic, like a patient is having increased QP or increased flow, like hyperkinetic, when a patient is heart size will be large, but in obstructive will have a normal. Then coming to the parasternal impulse, if a hyperkinetic patient will be having parasternal heave, like click of a pH is absent because this is flow related. Then they're coming to the S2 and coming to the hyperkinetic, like increased flow, wide and fixed, like you have already, you know that in ASD a patient is having wide and fixed S2, you will have the same. The second in VSD, wide and variable, but when obstructive, the patient, that will be single second heart sound. Now the murmur of the shunt will be loud in the case of hyperkinetic because this is flow mediated, and the flow murmur you will see in a patient of hyperkinetic. In the cases of ASD, so usually you see a flow murmur, the young, the 10, 20s, 15 to 20 years coming to you with patient with ASD, they usually have flow murmur. That is a soft sign to diagnose a patient as having hyperkinetic PH, or we need to intervene for that particular defect. Now, PH associated with congenital heart disease. So the clinical feature depends on the which defect is and which type of repair or palliative surgery you have done. Like if a patient is unrepaired any shunting lesion, the patient will be having cyanosis, polycythemia. These are the signs where you can say that patient is having unrepaired shunting with high PVR. Means either the Eisenmeringation has already been there, and in a patient PAP, the second variety is PAP and PVR marley even in the presence of normal oxygen saturation. So these are the patient where you will look for the value of pulmonary arterial hypertension, and you can see the saturation is normal. You can go for cath study of those patient and you can level the patient operable or not. In that scenario, this is important. Now, second scenario, if a patient had undergone Fontan or bidirectional vein palliative surgery, the sign and symptom include, if patient is well doing, is on follow up with you, but when a patient had poor exercise tolerance, peripheral edema, pleural effusion, and their protein losing enteropathy, decreased appetite, the most common symptom they usually come is a decreased appetite. So these are the protein losing enteropathy and different symptoms that patient usually come with PH. Now coming to the investigations, when you come to the ECG, that suggestive RVH so PH is usually give pressure on the right ventricle. So the signs will be the right axis deviation, the R by S ratio in lead 1 in V1 will be more than 1. The R wave height is 7 mm in V1. And important, if a patient is having right bundle branch block, then the height of R prime will be more than 10 mm. Important, RBBB and tall R wave more than 10. Some study says more than 11 as indicates right ventricular hypertrophy. And when we say the QR complex, even V1. So we'll have ECG. This is the ECG of the patient. This is a sample ECG. We can see there's a tall R wave in V1. There is STD changes in V1, V2, V3. So the right forces are dominant. You will having more V1, V2, V3. So the height of the R wave is important. RV strain as well. You can see the axis is towards right side. Okay. So these are the soft finding where we'll see the right ventricular strain or the patient is having pulmonary arterial hypertension. So these are the some lab parameters that we usually do: routine blood profiles, the pro-BNP level, connective tissue disorder evaluation, and coagulopathies. These are very disease specific. The kind of disease you will see, you will investigate in that. So we'll came to ECG. Now coming to the chest X-ray. So it's a very important. Like a normal chest X-ray does not exclude that patient is not having hypertension. So most important, you can see the star mark on the right side. The dilatation of the main artery is a common finding with severe PH. Like cardiomegaly suggests RV dilatation. We all know that the cardiomegaly is usually seen by the cardiothoracic angle. And important is peripheral pruning. Peripheral pruning means loss of pulmonary vasculature in the lateral one-third of the pulmonary bed. Like you can see the aberrant, the peripheral pruning means there is an absence of pulmonary vasculature. You can see in this diagram, in this X-ray, that peripheral there is a loss of vasculature. You can see to the mid in the medial most and the middle part, but absence in the lateral part. As well, you can also appreciate the cardiomegaly. So lateral chest X-ray is also important, where you can see that the filling of retrosternal space. We can see there is a presence of retro. It is normal. The left side of the screen has a normal X-ray, but you can see there is a filling of retrosternal space. That the reason the presence of parasternal heave, you can feel at the filling of that space that you clinically examine, you'll get parasternal heave. Now this is you can also see the difference in the size of the heart, the A to B. Normally the lower portion will be more in PH. These are the older soft signs that used in X-ray, those to look for the pulmonary arterial hypertension. Now there is certain criteria or certain numbers, like in a X-ray in a males, when the right pulmonary descending artery, the diameter is of more than 16, 17, a range some say 15 to 17, then there's a signs that patient is having PH. And in female, size a bit smaller, means it's 14 to 15, you can say, the right descending pulmonary artery, that is usually seen with the skygram. You can level a patient to having PH on the basis of suspicion. Now the important, the echocardiography. So echocardiography will not give you the gold standard value of pulmonary artery pressure, but it will definitely give you the rough idea, the level of pressure the patient is having. Like echocardiography evaluation of PSP, fact that PSP, like if there is a no obstruction to the RVOT, right ventricular outflow is normal, there is no obstruction, then you can say that pulmonary artery systolic pressure is equal to right ventricular systolic pressure, that is calculated by the TR velocity. So PASP equal to RVSP. So we'll get the rough estimate of the pulmonary artery systolic pressure. So there are certain equations that has been described earlier, that mean pulmonary pressure is equal to 0.61 into PASP plus 2. So you can calculate RVSP, then you calculate PASP from the same by adding the right atrial mean pressure. And how you calculate right atrial mean pressure? That is easy. You can look into the IVC, the dilatation of the IVC, the respiratory variation that will give. Like if a patient is having IVC with respiratory, minimal respiratory variation, you suspend the pressure is more than 8. So you can add that particular pressure and you will get a rough estimate of PSP, and with the PSP you can get the mean pulmonary arterial pressure. And you can also calculate the PVR by the means of echo. These are the equations that are not valid everywhere, but you can get a rough estimate. Like peak TR velocity by the RVOT VTI, if you multiply it by 10 and add into 0.16, you will get the PVR in Wood units. So there are some pitfalls, like in some patients will not get the proper TR jets. Study it was around 10 to 20%, you will not get the TR jet, so you will be unable to get the TRG Vmax. There is incomplete envelope because jet is not symmetric, it may be eccentric, or maybe multiple jets you can see. Or if a patient is having free TR, means there is a non-coapting tricuspid valve. In the patient you will having free TR, so there is an underestimation of PASP and the severe pulmonary arterial hypertension, because there is low peak TR velocity. If a high pressure is there, because regurgitation will be low, so there will be low peak TR velocity, and there are some issues associated with the RAP estimation. You will get a rough estimation by IVC, looking to the IVC dimensions and its respiratory variation. Like there are some soft signs like qualitative features that suggest elevated RAP in echo. Like if RA is enlarged, the persistent bowing of IS towards left side and dilated IVC and hepatic veins will be indicating parameters in next few slides. Like there are other signs in echo, like where hepatic vein flow velocity. Normally there should be no prominent flow reversal. You will see in the left side there is a no prominent. The waves upside the line, the baseline, there is a no reversal. As RV filling pressure increases, reversal become prominent. Like you can see in the right side, there is S wave. You will see the SR, that is the reversed. The diastolic, you will say DR. So these are the reversal waves that you usually not see in a normal patients. If there is RV dysfunction, you can appreciate these parameters, and these are the signals that RV is failing or increased VA pressure is there. So when you can also, this signifies that like the VTI of systolic flow by plus diastolic is divided by the systolic. If it's less than 55%, it signifies that patient is having RAP more than 8, and it has a good sensitivity of 86 and specificity of around 90%. So this is another parameter, PA acceleration time. So normal value more than 147, 140 milliseconds. Like the time to reach the peak, it is PAAT, artery acceleration time. You can see in this figure that RV ejection time or pulmonary acceleration time. So you measure the time from the initiation of ejection to the peak of the ejection. The normal more than 40. If it's less than 110, that signifies that patient is having PEH. So you can also calculate mean pulmonary artery pressure and index PVR by some formulas given by some Levy PT and Patel MD in this Echocardiography journal, and this give a rough estimates of PA pressure and pulmonary vascular resistance. Now, after evaluating the PA, you can also assess the RV function. RV is better for volume work. Now we say that LV is for pressure and RV is for volume. So when there is an afterload mismatch, then RV will definitely dilate. So first thing, LV eccentricity index, the normal LV is circular, normal index. When you RV by LV ratio is increase, means normal 1, mild septal flattening will be 1 by 1.1 to 1.4, moderate 1.5 to 1.8. If the severe means more than, if LV is compromised, in echo we usually say D-shaped LV cavity. So the eccentricity index like is the D1 by D2, end systole. So D2 by D1, when you calculate D2 by D1, if it has been changed, D-shaped LV cavity means now the circular shape has been changed to D. So this says patient is eccentricity index has increased and RV is getting bigger, annual is getting smaller, and RV is starting to fail. So the TAPSE, so this is a very reliable and reproducible, it's simple index for RV systolic function. So normal value is more than 16 and it's good correlation with RV ejection fraction. So systolic excursion of tricuspid annulus is calculated in when you apply a M mode to the lateral annulus tricuspid valve. So in adults, this is normal value is more than 16, but when coming to the infants, coming to children, you can see you have to calculate the Z score for that particular age group. It's not key if a patient is coming to you, if a child comes to you and TAPSE is 14 and you level the patient is having RV dysfunction. No, we have to calculate Z score and according to level the RV function. This value of 16 is valid for adults. Now, as earlier we are talking about IVC. So there are certain things you should think. Imaging in supine position, perpendicular to the long axis, the measurement should be taken. You have to take inner H to H diameter and just proximal to junction of IVC with hepatic vein. The better you select 1 to 2 centimeter proximal the entrance of IVC to RA, that will give, and you have to put a M mode and you have to look the variation, the maximum to the minimum variation. If it's more than 50%, you can say RVC is collapsible. If the variation is less than, you can grade according to that, the RA pressure. If it's less than 50% collapsible, you can say the patient is having elevated RA pressure. So when you see an enlarged right ventricle, these are the another sign RV enlargement in a plaques view and in 4-chamber view. We can also measure the basal diameters of the LV by RV. If the RV basal diameter is more than LV, there are signs that RV dilated, or you can roughly say that RARV dilated, and you can estimate the degree of RV function. There are certain other parameters like systolic to diastolic ratio from TR velocity. You can see that there is a TR jet is there. So TR is regurgitation, is a systolic pan-systolic event. So when you make a ratio of systolic to diastolic duration, you can see that if the systolic to diastolic is less than 1, the patient is having low risk. But as the S by D duration increases, like you can see here, if S by more than 1.4, the patient is having more risk, high risk. So similarly, you can level a patient, like a patient comes to you with the TR. It's not only you level a patient is having RVSP of 46 plus REP. You can also calculate the SD ratio, and subsequent treatment with the patient, the diuretics or a kind of RV function modification agent you give, you can assess the S by D ratio that will help the patient, and you can quantify the management of the patient. So tissue Doppler index, there is a certain other parameters like RV S prime, we say the velocity of RV contraction in longitudinal axis. Like you put a patient in tissue Doppler index and you calculate the S prime. You can see in the diagram the S prime. You can see the above the baseline. You can see the pointer is showing 8. So if it's less than 10, that's present low cardiac index. So in this particular diagram from our patient, you can see that it corresponds to 8. The patient must be having RV failure. So now the TI index. So TI index is again a sensitive marker. It will give you impression of both RV systolic and diastolic function. So this is the IVRT plus IVCT by RV ejection time, isovolumetric relaxation and isovolumetric contraction, and divided by ejection time. So higher value will give you the patient, you can know that decreased survival. These are the there are various studies have been performed on the basis of TI index, the RV is failing or not. So in a patient of PH, you can calculate TI index and see the severity of patient. Like you can see the pointer in the diagram or in the picture, you can see that there is a contraction time IVCT, there is IVCT, and the second star to the in the first star to second star the ejection time. So IVRT plus IVCT by RVET, that is the TI index. So if how will you say that patient has pulmonary hypertension? There are certain parameters like TR velocity more than 3.4. If TR is 2.9 to 3.4, or you have the second indices like basal diameter of RV is more, eccentricity index, PA diameter or RAP. So these are the certain when a patient is having high probability that patient is having PH. Now intermediate probability in the velocity is 2.9 to 3.4 and secondary indices are absent, and TRV is less than 2.8 and secondary indices are present. These are simple equations, and low probability when you get a TR velocity less than 2.8 meter per second and secondary indices absent, the low probability of pulmonary arterial hypertension. So USG abdomen, this is the Abernathy malformation congenital, where an extrahepatic portosystemic shunt, where you can see the pulmonary vein, this splenic vein and the mesenteric vein drains into portal vein. So you should always perform an USG abdomen to look for the venous system, Abernathy malformation. This is the cause of pulmonary arterial hypertension. We usually come across in our institute of Abernathy malformation. So USG abdomen to be done in young patients. CT can also be performed, that will give you certain cause like most important is the dilatation of the male pulmonary artery. This is the rough more than 29 millimeter. The second being the ascending aorta. So when you take a cross section, the diameter of the main pulmonary artery, when you divide with the ascending aorta, the ratio is more than 1. That's the soft marker that patient is having pulmonary artery enlarged, or there are the changes of pulmonary arterial hypertension. So this is seen in Framingham heart study. The normal mean PA to ascending is 0.7, but if the more than 1, it is a high positive predictive value. There is a various studies where right heart catheterization derived of mean PI pressure is having sensitivity with the detected pH. So CT is a good marker. So you can see at the level of ascending aorta, the PA is in the CT film, you can see the PA is dilated. Now the CT pulmonary PAgram so it is very important. In the plain CT, you can see the signs, but when you do the pulmonary angiogram, you can see the vascular changes. Like in a CT PH, level you can level the level of obstruction, like the secondary pulmonary artery or tertiary, or you can see the peripheral or any segmental pathology is there or not. You can appreciate the central PA dilatation. You can see the thrombus. You can quantify the amount of lung that is involved, like this certain signs have been described, like red tail appearance of the PA branches, means there's a narrowing of the distal PA pouches, webs, and post-stenotic dilatation. So there are certain signs like corkscrew-like vessels in a patient with group 1 pulmonary arterial hypertension. There's a rapid tapering that you in X-ray you also see. There is an absence of pulmonary vasculation lateral 1/3. That is the same in a patient you see in the CT, like peripheral pulmonary artery, and that are corkscrew-like vessels. So another is reduced PA distensibility. That is measured by ECG gated CTPA, where you can see that PA is so much dilated. Normally PA pulsatility can be seen, but the distensibility is reduced. Okay. Now this is the test CPET, where CPET is basically overall estimation. It is very important. By performing a CPET, you can differentiate a patient that is having a cardiac problem or pulmonary problem or metabolic problem. So this is very sophisticated test. There is an effort independent ratio of minute ventilation to the carbon dioxide production. There is various signaling, like I was earlier describing about exercise pH. So you can easily identify a patient is having exercise pH and the various changes in the pulmonary tidal volume and the pressures you can appreciate. So this is useful, and if a patient is being leveled, is posted for heart transplant, if a patient is posted post heart transplant patient, you can easily see the level of exercise, the kind of changes, and how much is the exercise capacity of the patient, and how the pulmonary vasculature behave. You can easily see with the CPET. So the MR, now we are in the generation of cardiac MRI. So pediatric PH patient versus RV size mass. So for the looking for the LV and the regurgitation fractions and different, MRI is a gold standard. So you can also, this is very important, you can easily measure the level of QP, the level of pulmonary flow, the biventricular function, the anatomy, and different mechanical properties of pulmonary artery can also be seen by cardiac MRI. So like group 1 IPH, we had seen that the patient was having genetical markers, like we say the bone morphogenetic protein is more than 75% cases of hereditary PH belongs to this group. So this is very important. If a patient of IPH, you have to test for this. So you can counsel the patient that this can be in your family and hereditary PH. So that's important. If you see 2-3 generations those having this kind of, so you can assess the patient by that. Now coming to the cardiac catheterization. So this is gold standard to confirm the diagnosis and the severity of the disease. So a response to pulmonary function, vasoreactivity test you can do, and determination of suitability of heart and lung transplant. So what are the parameters to be assessed? For the heart rate, you have to look for right atrial pressure, you have to look for PA pressures, the wedge pressures, the cardiac output, and PVR and SVR, and arterial and venous oxygen saturation. So when you do a right heart cath, this is very important. You can get the pulmonary flow, the systolic flow, the systemic flow. So after calculating these and the various responses, like if a patient comes with a borderline pulmonary arterial hypertension, you are leveling it to be moderate to severe PH, and you have to close the defect. That all to be determined by the right heart cath, and operability to be decided by providing the patient reversibility by providing oxygen, 100% oxygen, or nitric oxide, or patient on the milrinone. So we also seen that blood pH has an important effect on the tone of PA in the children. So this is important. At what time you are assessing the patient the PA pressure? Like a patient is having a severe metabolic acidosis. At the time there may be patient having a different PA pressures. Like similarly, if a patient is like an infant is in sepsis and is having LRTI, in the patient hypoxic. So there are the certain parameters we have to look in a child before looking to PA pressures. Like different conditions or different disease may impact the PA pressure, especially in young age group. Not to say young, in an infant and child. So this is the vasodilator testing. When a patient so in a patients of IPH, where you have very limited options for treatment, so if you want to give calcium channel blocker, so this testing to be done, it will see the operability or the long-term prognosis of the patient. So there are two criterias. You reduction in the mean PA pressure more than 10 to reach an absolute value of less than 40, or increase or unchanged cardiac output. The cardiac output needs to be unchanged but did not to be decreased. Then the second, the BAS criteria, where the MAP decrement decrement in the mean PA pressure of 20% with an increase or no change in cardiac index. So these are the two criteria. So this testing in congenital heart disease undertaken to assess whether the PVR will decrease. So we do this for the sufficiency for the repair to be undertaken in borderline cases, like the patient is having severe PH or moderate to severe PH and you want to operate the patient. Okay, so positive for borderline cases with post tricuspid defined as a certain parameter like PVR is less than 6 or PVR to SVR is 0.3. These are the some criteria that usually look for the operability. Okay, thank you.